Hello, I am Dr. Priyanka Alurkar, consultant radiation oncologist in Ahmedabad. In my previous video, I had spoken about radiation therapy in breast cancers, which you can access by clicking on the I button. Today, I am here to speak about radiation in brain tumors. Brain tumors can be classified into two types, primary brain tumors and secondary brain tumors, also known as metastasis. So, primary brain tumors are the tumors which originate within the cells of various parts of the brain like gliomas, meningiomas. They basically originate from glial cells, which are the supporting cells of the brain, or from the lining membranes of the brain, which are known as meninges, or the neuron cells. And secondary brain tumors are originating from other organs like breast, lung, kidneys, colon, and then they spread to the brain through arteries. This is known as a hematogenous spread of the tumors. Metastases occur more frequently than primary brain tumors. What are the symptoms of brain tumors? There is a wide spectrum of how brain tumors would present. It depends on the size and location of the tumors. As the brain tumor grows, it compresses the nearby structures and causes symptoms in the patient. The most common symptoms are headache, vomiting, nausea, and convulsions. Now, headache is not alarming as such, but if the headache is persistent, it occurs frequently and worsens with time, it is of more intensity with time, then it is worrisome. You should consult a doctor in that case. The other symptoms of brain tumors could be loss of imbalance, weakness in arms or legs, difficulty in coordination, difficulty in speaking or understanding a language, memory loss, blurred vision or double vision, etc. Similar to staging in other cancers, in brain tumors we do not have staging, but there are grades of brain tumor: grade 1, grade 2, grade 3, and grade 4. As the grade increases, the aggressive nature of the brain tumor increases. So, grade 4 is the most aggressive one, and grade 1 is a benign one. The treatment depends on the grades of the tumor, and also it helps in predicting the aggressiveness of the tumor. Grade 1 and 2 are known as low grade tumors, and grade 3 and 4 are high grade tumors. Grade 1 is generally very benign, so only surgery is enough for the treatment. Grade 2 are low grade, so if there is a residual after surgery, we might require further treatment like radiation therapy or chemo. In grade 3 and grade 4, surgery alone is never sufficient. You would always advise radiation and chemotherapy after the surgery. The treatment of brain tumors depends on the location of the tumor, size, number of lesions, and the grades. The aim of treatment is to remove the tumor as much as possible with surgery and then prevent the recurrence with further therapies like radiotherapy and chemotherapy. So, it is a multimodality treatment, a combination of surgery, chemotherapy, and radiation therapy. Sometimes, if the tumor is very small in size and it produces no symptoms in the patient, it has been incidentally detected in the patient, then we might also observe the patient and no treatment would be indicated. Observation meaning, of course, the patient has to come for regular follow-ups with imaging like MRI every 3 to 4 months. So, why is radiation required? First of all, when surgery is done, the tumor is removed by the surgeon as much as possible. But in some cases, the recurrence rates are very high, especially in high grade gliomas. So, in that case, radiation therapy helps to prevent a recurrence and offer the patient a longer survival. In some cases, the surgeon might find it very risky to remove the tumor because of the location. If it is located very close to a critical structure, the surgeon might not be able to resect it completely. In that case, radiation would be the mainstay of treatment. And in case of brain metastasis, palliative radiation can be offered to relieve the symptoms. So, the usual treatment plan for primary brain tumors is 50 to 60 gray in a 25 to 30 fractions over a period of 5 to 6 weeks. It is given along with chemotherapy, daily oral tablet of temozolomide. It acts as a radiosensitizer. It potentiates the effect of radiation. Along with that, supportive medications like antacids, medications to prevent vomiting, steroids, anti-epileptics to prevent seizures might be given. The commonly used techniques to deliver radiotherapy are 3D conformal radiation therapy, IMRT or intensity modulated radiotherapy, SRT or stereotactic radiotherapy, and proton beam therapy. I'll be discussing each one of them in detail. So 3D CRT and IMRT are the techniques which confirm the radiation dose maximum to the tumor and spare the normal tissues that are surrounding the tumor. So this helps to reduce the side effects. IMRT has an additional advantage of dividing the beam into small beams or beamlets with different intensities. It is usually accompanied by imaging. Imaging is done, and under the guidance of these images, radiation is delivered. So this is known as IGRT. As of now, IMRT with IGRT is the standard of care for brain tumor radiation. Stereotactic radiosurgery. Now, this is a technique which delivers a very high dose in few number of fractions very precisely to the target. The ideal candidates for stereotactic radiotherapy would be tumors less than or equal to 3 centimeters, less number of lesions, and tumors which are located away from critical structures. Again, the aim of treatment is to focus maximum dose to the tumor and less dose to the surrounding normal tissues. So there are less amount of side effects. It is usually done for metastatic brain tumors and sometimes also for a few select primary brain tumors. In earlier days, metastatic brain tumors were treated with whole brain radiation. So it used to be a treatment of 10 to 15 days, which would delay chemotherapy further, and also there would be more side effects because you are radiating the whole brain, whereas in stereotactic radiotherapy the dose is focused to a very small area. There is another technique called SRS, which is known as stereotactic radiosurgery. It is not actually a surgery, it is a misnomer. It is an absolutely non-invasive technique of delivering radiotherapy in a single fraction, and it is a very high dose fraction. Now coming to proton therapy, it is used to focus the radiation to the tumor in a better way and more precise than the 3D CRT or IMRT. It is highly beneficial in pediatric patients and in recurrent tumors. Our biggest worry as a radiation oncologist in pediatric patients is that when the children grow up, they have neurocognitive defects, memory effects, low IQ, second cancers, all these risks because of radiation. So in order to protect the normal brain tissue, we use proton beam therapy in such cases to focus the dose to only the tumor. And the peculiar property of a proton beam as compared to a conventional X-ray, which is used in the previous techniques that I mentioned, is that when a proton beam enters the body of a patient, it delivers all its dose to the tumor and then does not exit beyond that point. Whereas in an X-ray beam, it exits from a point opposite to the entry point. So what happens is a normal tissue is radiated beyond the tumor also. The side effects of radiotherapy can be divided into acute and long term. So the acute side effects are very minor, that is focal hair loss, fatigue, nausea, vomiting, some amount of scalp irritation on the skin, and drowsiness. So the hair loss is only focal, as I mentioned. It is not an overall generalized hair loss as people think there is in chemotherapy. The long-term side effects depend on the location of the tumor. So these are mainly neurocognitive defects, memory defects, decreased vision, decreased hearing, etc. So if there is a patient around you with the following symptoms, please consult an oncologist as soon as possible. And my contact details are given here. So for any queries, you can reach me on this contact number and email ID. Thank you.